I'm very pleased to be here with Karl Brasser. Karl, you demonstrated a beautiful, beautiful presentation on YAG vitriolysis for floaters. Let me have you talk me through, first of all, what the procedure is, how it works, and what your experience is when you're actually doing the treatment, what you see and how technically challenging it is.
So, Josh, it's a great pleasure to be here talking to you and getting the invitation. So, a year ago at ESCRS meeting in Amsterdam, I came across a laser that is able to go deep into the vitreous and to do laser treatment of floaters. You and I, we have so many patients that are frustrating of floaters, and what they get to hear from us
of course,
is you got to live with them, or you have to go through a vitrectomy. You know as well that vitrectomies, you really have to think about it for young patients, all those complications they have in front of them. So I got so excited, I needed a YAG laser anyhow, and I got it, and I started to do YAG laser treatments in the anterior segment, secondary cataract, iridotomies, and this laser worked so well because the company Alex, the new laser from Alex, has the property that all 6 beams are parallel to each other. It is the illumination beam, the observation beam, 2 observation beams, the 2 targeting beams, and the laser beam. And using a correct lens enables you to go deep into the vitreous and to do a safe procedure there. Of course, like all of my colleagues, I was quite suspicious and thought, well, can you do that? What happens? But I started in the anterior segment of the vitreous and noticed that my YAGs, capsulotomies, they were so beautiful and so much more controlled and so much better that I got confidence to go deeper. I started to learn. I started to shoot into the vitreous, deeper into the vitreous. I started to cut strings and little globules, and was surprised how wonderful that worked. Now, the key when you want to get rid of floaters is not just to cut them. This is what I first thought. I had to learn. I went through the physical basics of laser surgery again. John Karikoff from Virginia, who is the mastermind behind this procedure, he developed it over the past 20 years. He even brought 200 patients to study with the FDA, which was approved. And he has a few supporters like James Johnson in Orange County, who just does do floaters. But I'm surprised still that not many colleagues are doing the procedure. I predict that with the work they see from more patients now, colleagues now using the laser, that many of us will offer the procedure within the next 5 years. For me, this is really the procedure of the past year. And so what happens with the laser treatment? You focus on the floater, and with the YAG you create a temperature of 4,000 degrees in the point of focus. You create a plasma, which a gas consisting of ions and electrons with a lot of energy, and this melts solid matter away and brings it into gas. The key is to vaporize the floater, not just to shoot it into pieces. So no patient would be made happy. That is basically the procedure. Still, we are deep in the vitreous. You have to fulfill certain guidelines that you have to have a distance of 2 to 3 millimeters from the retina, and on the other side stay away from the lens. When you start the procedure, it's much easier to start with pseudophakic patients. Then you just have to take care of the retina. So still, colleagues will ask, and patients as well, why are you just doing it? it's like with the invention of the phaco machine. So many people were hesitant, and some colleagues had a hard time. But still, I absolutely believe now that this is a wonderful procedure, safe to do, and with a short learning curve.
Is it technically challenging?
Not really. We all know how to use YAG lasers. Colleagues putting in lenses and doing YAG laser treatments of the capsulotomies will be able to do this as well.
No, you were telling me that the energy settings that you use are higher than I'm used to using for capsulotomies.
That's right. You see, you can talk hours about the procedure, about the details. You need a higher level of energy because a lot of the energy is resorbed on the way to the posterior vitreous. In particular, if you're dealing with high myopes, then to have the same level of effect, which you know from the anterior chamber, from the IOL, it has to be 2 to 3 times higher.
Oh, I see, just because there's a lot of tissue
That's
that
right.
you're passing through. I saw that you use settings as high as 22 millijoules per shot.
That's right. You have to, on the average, use an energy of 7 millijoules to get to create a plasma effect in the vitreous. And when you feel safe that you have a lot of distance to the retina or to the natural lens, then you increase it with the multiburst mode and reach levels of 21, 25, and then the floater melts away.
And what is the total energy that you deliver to an eye with an eye with a substantial floater, let's say?
So I was skeptical at the beginning. I started just with 500 millijoule, but I haven't had all of the floater. Then I got more confidence. I increased it. In between, I stopped the procedure again. Have taken the patient to the slit lamp, have done an optoscan of the retina, checked the pressure, looked for cells, did it in a couple of days, not the entire procedure in one sitting. But never ever something happened. I told you that I've done this study now with 100 cases. I haven't had one complication.
Yeah, it's really something, and they're beautiful pictures. Very, very clear. Mm-hmm. And Carl, this is really neat stuff, and it certainly is thought provoking. Because I don't do this, and my colleagues don't. But it's certainly something for us to consider. Carl, I want to thank you very much for bringing this to us, bringing these beautiful photographs, and for being so generous with your time with us today.
Well, it was a pleasure doing that. Thank you so much for your time.